After completing his pediatrics residency at the American University of Beirut Medical Center, he moved to the United States, repeated his pediatrics residency, and completed a fellowship in neonatal perinatal medicine at the Women and Children's Hospital of Buffalo, University of Buffalo in 2012. Upon finishing his fellowship, Dr. Khoury joined the Division of Neonatology at the Children's Hospital of Richmond at VCU as an assistant professor and was promoted to associate professor in 2020. He serves as the medical director of the Neonatal Transport and Outreach Program and associate medical director of the Neonatal Intensive Care Unit. In 2017, Dr. Khoury was one of the co-founders of the Virginia Neonatal Perinatal Collaborative, where he serves as co-chair and neonatal lead until July 2023. After stepping down, he continued to serve as an ex officio on the VNPC board of directors. Currently, he serves as the manager of the VNPC, and in this role, he conducts weekly meetings with co-chairs and works closely with the senior director and other team members to manage daily operations for various quality improvement projects across Virginia. And Dr. Casella is an assistant professor of pediatrics at the Children's Hospital of Richmond at VCU Health. He is also the director of invasive congenital cardiology. Dr. Casella graduated from Eastern Virginia Medical School and then completed his postgraduate training in pediatric cardiology, interventional cardiology, and cardiac critical care at Boston Children's Hospital. He has been at VCU since March 2020 and can regularly be found on the pediatric wards, PICU, or in the catheterization lab. When he is not at the hospital, he can be found biking in Pocahontas or on North Bank. He cares for patients of all ages, from newborn babies to grandmas and grandpas. Complex cardiac physiology and novel percutaneous interventions are his passion, and he will be happy to discuss any interesting patients you may have. And so I will turn it over to them.
Thank you, Tiffany. Is it okay if I share my screen for the presentation?
Yes, absolutely.
Okay. Okay, so this presentation Dr. Casella and I gave at PAS back in May when we went up to Toronto. So we're just gonna go over that again with you guys. Please feel free to interrupt at any moment in time if you have any questions. This talk is divided into two parts. I will discuss transport and setting up the program, and Dr. Casella will continue talking about setting up the program and how the program is looking so far. So we have no, oh, sorry, I forgot this slide. I have no disclosures. We're not using anything unapproved or off-label. So just to go over this, initially we're just going to talk about the CHOR NICU where we work. I'll give a brief overview over our neonatal transport team because it's an integral part of this program. Then we'll talk about how creating a high volume referral center for the Piccolo closure, which Dr. Casella will emphasize on, and then getting kids in and out and standard pathways of treatment, and then communication with referring centers to make care transition smooth with them. So our NICU here at Shore is a level 4 NICU. We have 40 beds. Actually, yesterday we opened 4 new beds, so our capacity can flex up to 50 right now. We have 4 twin rooms and a procedure room and an OR room. In our procedure room, we can do ECMO, we can have minor surgeries, or we can repair congenital diaphragmatic hernia patients if they are on ECMO. We also do whole body cooling and dialysis. This picture here on the screen is a patient who's actually undergoing cooling, whole body cooling and ECMO at the same time. This is actually in one of our twin rooms. The procedure room was also taken up by another patient who was on ECMO at the same time. For our transport team, it was created in 1976. The initial model only had transport nurses on transport. MDs accompanied RNs only for critically ill patients. And over the years has undergone several changes just to keep up with how things are going in the state. In 2016, we started developing our flight program, and in 2017, we took our first flight. Currently, we average a number of about 10 to 15 flights a year. We're mostly limited by weather and maintenance of the helicopters. So overall, we miss about 10 to 15 flights. So if everything was fine with no weather issues or maintenance, we have about 30 flights a year. Our current team composition is a flight nurse, flight RT, and an MD if needed for critically ill patients such as ECMO or cardiac patients. This is the reach that we have for our referral centers. We cover a significant portion of Central Virginia, all the way up to Fredericksburg and Norfolk, Virginia on the East Coast. So talking about our NICU within Richmond, we are the only level 4 NICU. We have 2 other hospital systems with 3 private level 3s and level 2 NICUs in the city. We receive the majority of their referrals, which are chronic lung disease patients, major surgical interventions, including ENT and neurosurgery, and any other subspecialty consult that cannot be seen at their institutions, such as renal and GI and genetics. So even though we get a lot of these patients here within Richmond, there was a population that we did not get here, and these patients were referred outside of Richmond, and these are mostly the cardiac patients. So these patients did not come to Shore initially. They go either to Charlottesville or Northern Virginia and DC for the most part. There are downsides to doing this. There's increased costs due to out-of-state referrals and or longer transport distances, and displacement of families away from home for prolonged durations. And this leads to disruptions of school for the siblings, parents being separated, increases stress. One parent has to be far away at home, and the other parent has to be with the baby. And also there are some complications post-discharge because follow-up requires long-distance travel, and our coordinators in different places don't know what's offered in areas such as post-discharge management and nursing and everything else, so that complicates discharge as well. What Shore lacked was really the capability to provide cardiac care to patients within its referral pattern. So there was a need to change, and there was a time for change. So last year in April, a new building was opened. The new Children's Tower was opened. We have a lot of new providers. We're expanding our subspecialties, and cardiology, with the addition of Dr. Casella and Dr. Snyder, who's their chief of division right now. We got the capability to expand our program significantly. And cardiology discussed the initiation of a PDA closure program with the Piccolo device at Shore, and request was made to team up with neonatology to build and expand the program. And that's where I came into this. And at the same time, Shore, UVA, and THKD started collaborating for cardiac patients in Virginia with surgeries and referrals between the 3 centers to cover all of Virginia. So when you're building a new program, you have to establish different things. There's a lot going on with these things. So one, you have to create that multidisciplinary team that you need. So we had to create a cardiology. We had to bring in cardiology, neonatology, anesthesiology, nursing, and respiratory therapy all under one group to discuss creating this program. We had to establish guidelines. We had to collaborate with our referral centers and tell them, hey, we have this program, basically marketing the new program and building a relationship beyond what we already had with the centers that we service. And we had to create agreements between us and those centers just to make sure that everybody's on the same page at all times. And you also need a transport team, which is already established and is ready to go and bring babies as needed and take them back to where they came from. So again, going over the multidisciplinary team, cardiology was at the crux of this. Dr. Casella and Dr. Snyder, and we have a new surgeon, CT surgeon, Dr. Kogan. They work together with anesthesiology and the cardiac cath lab to coordinate all this and make it happen. From our standpoint, from neonatology, we had to coordinate the care and set up the teams that go with these patients to the cardiac cath lab and make sure that they're taken care of in the cath lab and coordinate with cardiology and anesthesiology while they're in there. Nursing and respiratory from the NICU, in addition to the attending, always join these patients in the cardiac cath lab to make sure that if there are any complications or any questions that arise, they're addressed immediately and they're not having to call the NICU for us to come down to the lab. My slides are not moving. There. Okay, so of course, for every new program that you build, you have to establish guidelines just to make sure that everybody's working the same way. Everybody has a clear understanding of what's going on. So Dr. Casella and I worked on these new guidelines. We shared them with our groups. They provided their input. And the highlights of these guidelines are that the hospital that calls us for the patient, so the referring NICU team, is always the primary decision maker. And our cardiology group is just for consultation. So we never tell them what to do. The team over there where they are referring those patients, they tell us that they make the decision for the closure, and then they consult us to work with them. If the patient qualifies for this procedure after discussion with cardiology, there is a NICU to NICU sign out, and transfer timing is discussed based on capacity and when the cardiac cath lab is available. Dr. Casella arranges a telehealth consult with the family if needed, just to discuss things before the family agrees to come to us, before they sign all the consents. We have blood work that is sent at the referring hospital to make sure everything is lined up for Dr. Casella and his team to perform the procedure. And then once the patient comes here, they do the procedure, and then we send them back to the referring hospital. This is like a high-level highlight for the guidelines. So collaboration is really, really important for us. This is the crux of this program. We are not here to take patients away from other referral centers. We want to work with them. We want to bring their patients here. We provide the procedure and we send them back. So this was the really important part of initiating the program. So we had to establish trust with our referring centers. We wanted to make sure that they trust us to send us these patients to us, as opposed to other places out of Richmond, out of state even. So factors that have facilitated this trust is that me being the medical director for the transport team, I already had all the contacts and connections with different medical directors in the city. And because I was with the VNPC for such a long time, I also had all these contacts. So it helped with this program to have all these connections outside of CHOR. We reached out and met with the medical directors of the referring hospitals in Richmond to introduce them to our newly created program and discuss the guidelines. So we went to each hospital and we sat down with them and we talked and discussed and got their feedback. And one really important thing that we did was, because we want to collaborate with them, we shared our guidelines with them as we were creating them. That way, they had their input to customize the guidelines based on their centers to their individual NICUs, so they feel like they're part of this. We're not just telling them what to do. They had some kind of input into how things are done to their patients. There is something that we had to work through as well, which was the need for a back transfer agreement. One time I was talking to one of the medical directors in the city, and it was, we're like, why don't you send us? We need to send this patient to us as opposed to out of town. And the response was, we don't send you patients because we never get them back. And this really hit hard, because we want to collaborate with everybody here. We're not here to play politics with anybody. We're doctors, we're nurses, we're providers, we're respiratory therapists. We're here for the patients first and foremost. So when I got that answer, I went to our CMO and our chair of department and I said, I would like to work on a back transfer agreement, which is an agreement between us and the referring hospitals, that they send the patients to us, we do what we need to do, and we send them back. And once I got the green light for this, we teamed up with risk management and legal from VCU to create a back transfer agreement to facilitate the movement back and forth of these patients. So the goal for this, the first and foremost important goal, is to improve collaboration between NICUs within the city of Richmond, because collaboration is really important. We're all here for the patients. We want to make sure that they get the care they need close to home as opposed to distant places. We needed to improve trust between providers and hospital leadership, and we wanted to show good faith on behalf of CHOR with transferring patients back to the referring hospital so they can continue care there. Secondary, we wanted to keep families close to back. We wanted to send families back to the providers. Sorry, my computer is acting up before it locks on me. I am so sorry. Epic likes to kick you out of your computer if you don't activate it for a certain amount of time. Um, so the secondary goal was is to keep families close to their local providers, make sure that they get their high level of care close to home. And we also wanted to decrease costs by avoiding transports out of state and other regions of the state. And also, finally, with persistent capacity concerns at shore, and not just at shore, if you look at the state, the level 4 NICUs or the subspecialty NICUs within the state, not just shore, we have UVA, INOVA, CHKD, we're always full and over capacity, so we're having to turn patients away. The advantage of having a back transfer agreement is we can send patients back to where they came from, so we can open up space for more patients to get accepted. So this is a copy of the back transfer agreement that we created with our legal department and risk management. The way this works is that we introduce families to the concept early by the referring neonatologist. So say, for example, there's a baby at hospital X that needs to come to us for this procedure. The referring physician at that hospital talks to the family and tells them, your baby is being sent to shore for this procedure. Once they are done, they're coming back. That sort of puts the idea in the parent's head that my baby's coming back to this hospital. Once our transport team gets there, they reiterate the same thing. They say, okay, so we're going to pick you up. We're going to shore. We'll do the procedure. Once that, we're going to bring you back here. And then the same thing happens with when the baby gets to shore, the attendings repeat the same thing. This was really important because previously we didn't have that. So when we came to tell parents you're going back, that was a shock to them. So this is basically preparing the parents, telling them you have to go back when you're done. And it's not legally enforceable, so we cannot tell them, okay, you signed this agreement, you have to go back, you have no choice. But it's also, but in a way, it sets the expectation for that family that they are going back. So when we had the guidelines ready and we had the back transfer agreement ready, we went out and we met with all our referring hospitals within the city of Richmond. And the team from Shore was a team from neonatology, cardiology, CT surgery, and our associate CMO went out. And over there, where we met with the different hospitals, we didn't want to just meet with neonatology and cardiology. We wanted to make sure we met with nursing and everybody's involved in the care of that patient because, again, collaboration is really important in this program. We discussed the guidelines with them. We emphasized the back transfer agreement. We emphasized that the patient will be transferred to Shore for the procedure only, observed for 3 days and sent back. The patient continues to care at the referring hospital, and after discharge, the parents are free to choose whatever provider they want to follow up with outside of the hospital. So we don't tell parents, you have to follow up here with us. You can go wherever you want. So the highlights of the program is that it's a 2-day, the patient comes to us 2 days prior to procedure. The day of the procedure, anesthesia, cardiology, and neonatology perform a pre-op huddle. We call the hospital to update them and confirm that everything's clear. We're going to go forward with this. On the day of procedure, again, the NICU goes down to the cath lab with anesthesia and cardiology. We remain there. We back Dr. Casella up in case he needs anything. The patient's transported back to the NICU. We do a post-op huddle for this patient, and then we call the referring hospital for an update. So constant communication with other referring hospitals is really important. Again, collaboration, this is the main word. We've had a number of patients come to us since the program has been created. Dr. Casella will go over those. And since we instituted the transfer back agreement, it's been easier for us to send patients back to the referring hospitals with less resistance from the families because that was the expectation that they had when they came to us. And we're also expanding this program for the back transfer to other patients as well, because again, we want to continue collaborating with our referring hospitals. So we're not just limiting it to the Piccolo procedure for the PDAs. We're also expanding it to other surgeries and ECMO. So when patients are taken care of, they're cleared by surgery, they can go back to the referring hospitals. In order to make sure that everybody's on the same page as to what patients qualify to going back, we had some exclusion criteria. This is what we have in our unit just to make sure that people know when the patients are eligible to go back and if they are or not. So if a patient came from a level 1 or level 2 facility, obviously they can't go back if they need continued NICU care. If the subspecialties that need to continue with these patients are not offered at the referring hospitals, if the referring physician themselves say, don't bring this baby back to us, we can't handle this kid, or if there's any other reason deemed by the attending that is valid to keep the patient here. The future plans for this is to expand this to the PICU and acute care peds floors. Adult Services is planning to adopt this as well. And we're planning on expanding this program outside of Richmond and outside of Central Virginia. And the major issue that we're dealing with is insurance. So we're working through this process to make sure that the insurance covers the back transfers as well. And that's it for my part. I think Dr. Casella should go next, and then we'll answer questions at the end together. So we can give him time to present his part.
Thanks, Joe. Can you give me a thumbs up if my screen looks good? Thank you. So I'm Samuel Casella. I go by Sal if you ever see me on the street or whatever. And I'm going to be talking a little bit more about the PDA closure side of things. I really, we have a unique thing here. I think that our relationship as cardiology and neonatology is just really strong at this hospital. And without that relationship, this never would have happened. And so I'm just really thankful to the neonatologist and Joe in particular, just for all the work that he's done in order to make all this happen. So just in brief, PDA closure, it's not a new thing. We've been doing it since 1966. That's when the first transcatheter closure was performed, but it was kind of antiquated, or at least now it is. But what's kind of interesting is the technology really hasn't changed all that much. They're basically all just various forms of plugs, although there were some kind of scary looking barbs that came along the way for some patients. And it was really in 1981 with the Rashkin device that we came up with these kind of double umbrella looking things. And the truth is that the technology really hasn't changed all that much since then. But we've gotten a lot smaller. We had different catheters that enable us to perform this procedure on smaller kids and less invasively. And despite having that technology around for such a long time, it wasn't until 2003 that we actually had an FDA-approved device. That was the Amplatz Ductoccluder 1, but that was only approved for 6 months and over 6 kilos. They got a new device in 2009, which again was approved for the same ages. And it really wasn't until 2019 that we had a device for the real neonates and kids as young as 3 days of age and as big as 700 grams. And that's the Piccolo PDA occluder device. So this is the only device that is FDA approved for PDA closure in these infants. There are other devices out there, but none of them are FDA approved, and we're not going to be talking about off-label stuff today. And so I'm just going to show this brief video. This is from the Abbott website, so you can look at it if you ever want to. What you can see is we go up through the femoral vein and up through the patent ductus arteriosus. And once we're through the patent ductus arteriosus, we put the catheter in there and pull it back over a wire, and we're able to take a picture through there. The picture lights up the PDA, and then we're able to deliver this device within the PDA. And that's what's the really unique thing about this device, is the device is completely contained within the PDA and doesn't extend on either side of it, whereas the other devices had to be outside the PDA to close it. But you can see here it fills up that little chamber, and then once we like how it looks, which is done primarily with echocardiography, we're able to unscrew the device off the delivery cable. And after it's unscrewed, it's released and everything comes out of the body and the hole is plugged. And 99% of the time, it's plugged right there and doesn't even take any extra time. So you can, if you just look at the Abbott website, you can watch this again, but it's a nice little illustration of what we do. Of course, it makes it look much easier than it actually is and prettier than it actually looks. This is what it actually looks like in reality. This is one of our patients. And you can see here the catheter is going up through the right ventricle. This is the pulmonary valve. And then it's through to PDA, which you can see here with the wire through it. And then after we put the device, you can see the device here, which is within the PDA, and there's still flow to both branch pulmonary arteries. So it's not quite as easy as they showed, but we're getting more adept at it every time we do it. And so just a brief review of the data that we have so far. I really credit Dr. Sathanamidam for all of his work. He's out at Lebanon in Memphis and has really pioneered this procedure. He's definitely done the most in the world. I commend him for really publishing as he learned and publishing a lot of consecutive cases, which when we're dealing with small numbers, I think that you have to publish everything, and there's a risk of bias of positive outcomes and not really talking about any negative outcomes. And he hasn't hesitated and has given really good data and been truthful and helped us learn from some of the mistakes learned along the way. And in 2019, he came out with the first report of 55 infants less than 1,000 grams. This was really before the Piccolo had been approved, and he was using a variety of different devices. He claimed 100% procedural success, but he did have 2 adverse events, including an LPA obstruction requiring device removal and a residual leak that resolved spontaneously. That same institution published 100 patients under 1,000 kilos, or sorry, 1,000 grams. And again, they were using multiple devices. But in this case series, they noticed a few serious events early in their series where they had an LPA stenosis, and then they actually had a patient death in an 840 gram neonate due to an IVC laceration. And another infant had a pericardial effusion requiring drainage. And they were all done with this, it's the Amplatz vascular plug 2, which was not an approved device. And after those 3 morbidities and mortalities, they decided to abandon that device. And from then on, they used the microvascular plug and the Amplatz Piccolo occluder. Following that switch, there was still an LPA stenosis, and there were 2 aortic obstructions. So overall, it was very successful, but there were serious adverse events that occurred along the way. And that led to the actual, the Piccolo occluder clinical trial. And so this was sponsored by Abbott, and it included 200 patients, of whom 100 were less than 2 kilos. And this was all using the Piccolo PDA device. And what you can see here is it was very successful, and they reported a 95% success rate. There were of the unsuccessful cases, 3 went to another device, 3 required surgical ligation. There were 2 embolized devices which were then exchanged for a different device. And then there was 1 that was just delayed because they weren't able to close the PDA. There were 5 embolizations, all of which were retrieved in the catheterization lab and closed in that same procedure. And there was 1 aortic obstruction, 2 transfusions, and 1 episode of hemolysis. So, you're dealing with adverse event rates in the about 2% range, but they're serious adverse events, and they're not really necessarily well tolerated in these really tiny infants. And we have continued to follow these kids. The most recent data was the 3-year follow-up of the continued access protocol cohort, and there was no accrual of any kind of morbidity after 6 months and up to 3 years. So once we're out of that, really before 6 months is really before the first month. Once we're out of that range, it seems that we're out of the danger window, but we're still obviously studying these kids. And the complications were recognized, and that led many of the experts in our field to come together and write this consensus summary paper where they spoke about each of the adverse events that have occurred and have given recommendations for catheterizers as ways to avoid having those complications. I won't go into details there, but we have recognized some of the complications and really worked to decrease that rate, because we know that where the tolerance for any kind of adverse event is extremely low. So who gets referred to us? So at the end of the day, it's the referring NICU who decides that the PDA needs to be closed. We are available, and if anybody has questions and wants to discuss a patient, we are happy to be involved. But at the end of the day, I'm really relying on the NICU. I think that they are the experts about these babies, and they're the ones that should be deciding whether or not a PDA is significant. We are happy to help make that decision, but it should be them that choose when a baby needs to come to us. You can contact us via the common phone numbers that everybody knows, but Joe and I also created a shared account, which it's this neocards@vcuhealth.org. And so that's an easy way to get in touch with either one of us with just one common number. And that way providers don't need to think so hard. You can just send the email and we'll take care of it all. We do like to look at the echo images ourselves before we accept a patient, because I want to make sure there's nothing glaringly abnormal. And then once we look at all the data, I look for anesthesia and cath lab availability, and then we work on transferring the patient. And it's a complicated procedure. It requires a lot of collaboration. You can see here, this is a real procedure happening in one of our patients. It's cramped. There are a lot of people that need to be there to make sure this goes well. And we're just fortunate to have an excellent team that really works together, and we communicate well in order to do the best that we can for these patients. And so what I'm going to do for the remainder of the time here is just kind of talk about our experience and the things we've learned along the way, because I'm trying to use the Le Bonheur experience as an example, and we are trying to be transparent and open about how the program's going and the things that we've learned along the way, because we're constantly trying to improve what we do for these patients. And so you can see here, we started big. So this is back in February 2023. I started with a 1900 gram patient, and I'm actually credentialed at UVA as well. And so for the real complex cases or new things that I don't necessarily have as much experience with, I'll actually do them at UVA, where there's two other interventionalists, and we can scrub the cases together. So this patient was my first Piccolo, and so we actually transferred the patient over there, and I went with the patient, performed the procedure at UVA, and then the patient came back to us afterwards. We then did another larger kid, 2800 grams. Both of these kids were kind of sicker. They had been in the NICU for a very long time. They had pulmonary hypertension in one of them. They had that patient got pulmonary hypertension, but they had a bunch of comorbidities and really severe lung disease, and they were older kids, 2.5 months and 3 months old. So we selected really kind of larger kids in order to have more room to work with. They were successful procedures, but I think that we were a bit late in the game at closing their PDAs, because one of them ended up getting a trach and G tube later, and the other one had a trach and unfortunately died at 10 months of age from unrelated complications. We then worked our way smaller, so we got down to 1100 grams. And this patient, this was early in our experience, and at that time, we did not have NICU with us when the patient, they transported, but then they weren't in the room when the patient was intubated. And that patient had bronchospasm during intubation by anesthesia, and he required a little bit of resuscitation. It never had CPR or anything like that, but it was kind of dramatic, and we required the NICU to come down and give us a little bit of support. And so from then on, we said, well, we want NICU here just because I think more providers is better than less. And especially with these very tiny babies, anesthesia is wonderful, but the neonatologists have the most experience with their airways. And so having all the providers in the room really has benefited us since then. I then did my smallest kid, which was 1000 grams. And because we realized this was the smallest kid we had done, I actually transferred this one to UVA as well and did it with the interventionalists over there. And at that time, the patient came down from the NICU, was already intubated, but anesthesia noticed a leak. And so they actually re-intubated in the cath lab. And then there was only one form of access, so they got another access at that time. And that just really led to a lot of delays in the procedure. There were no kind of bad outcomes for the patient, but it took a lot of time. And what we're trying to do is avoid time away from the NICU and avoid time in the cath lab where these babies are getting cold. And so it was an uneventful closure, but we recognized there were some things that we could do to improve after that case. That brought us to a patient that had been referred to us and was actually our smallest kid, which was 720 grams, who had actually a very uncomplicated closure. We instituted all the things we had learned, and the infant was successfully extubated 4 days later and transferred back to the referring institution. We had another referral the next month in October, and that patient had failed extubation 3 times and was still on the ventilator. And what happened here was that the patient had an elevated procal that we noticed that was sent the day before. But we saw the patient, the white count wasn't elevated. And we did blood cultures that the day before. The patient was completely asymptomatic, and so we elected to proceed with the procedure. Well, what do you know? After the uncomplicated closure, the blood culture resulted as positive, and thankfully we treated the patient. There were no complications, cleared the infection. But I think in retrospect, we probably should have waited an extra 24 to 48 hours with negative blood cultures before proceeding with that cath. We then had a 1,500 gram infant that was uncomplicated and extubated 11 days afterwards. There was one patient that was referred from our own NICU with a relatively small PDA, and I had an image of the child for about a week. And when we had the patient on the table and started with the echo, we realized that the PDA had constricted, and we ended up aborting the procedure before any kind of anesthesia or anything like that. But it would have been nice to not have transported the patient in the first place. We had an uncomplicated closure in a 5-month-old. And then relatively recently, we had a 900 gram infant, and we've been really working to try and do this procedure with echo guidance and not with fluoroscopy, and trying to decrease the radiation dose. And I got access with no problem, but I was having difficulty passing my catheter, and it just didn't feel right. And so I stopped, and as they teach us when we're becoming interventionalists, is if you're ever not sure of anything, take a picture. And so I did, and this was the picture that I got. And what you see here is that the catheter is going into an odd vein that you're not really quite sure what it is. And so I pulled my catheter a little further back, and what you can see here is that as I pull it back, what happened is my catheter had went into this little side branch, which is a branch that goes up the azygos vein. And so it was up this very tiny collateral vessel. And it was hard to know that because I wasn't using fluoroscopy at the time. And then as I pulled my catheter back, you can see the IVC light up. And so there was no harm caused to the patient just because we recognized something wasn't right and took a picture. But it just was a testament to how challenging this procedure can be and how much experience I have to gain just by doing more patients. And I just have a lot of respect for Shaman in Memphis, who has done so many of these cases. In April, we did a 2,800 gram infant with an uneventful closure. And then this past May, we did 2 more infants, both of whom had uneventful closures. However, one of them had a right main stem after we transferred the patient while intubated back to their isolette. It just took a few minutes to kind of figure out what was going on. put the patient back on the table, got a fluoro, realized what was wrong, repositioned the tube, and the patient did fine after that. And then in the most recent case, it was a bigger kid that had other cardiac anomalies, had an ASD and a VSD, and we were trying to decrease the shunt burden for this child. And this Piccolo, this is a bigger kid, we have to be careful about the Piccolo and the bigger kids. And the Piccolo was just not secure, and this is kind of what it looked like. You can tell I released it, and it's still on the cable, but it's really kind of bouncing around and just pulling through the duct. It's not secure. And we recognized that, and immediately we did not release that device. And I took it out of the body and replaced it with a larger, a different device, and successfully closed the PDA without any kind of harm to the patient. But it was my first experience of having a device that really was undersized, based on more of an elastic duct. It appeared appropriate based on our sizing before we selected the device, but the duct was just very compliant. So Joe and I have been working really hard to improve as we go, and one of the big things is time. And so we have been really keeping detailed logs of all these procedures. We have multiple time points that we are recording, and we're trying to improve as we go. And what you can see here is we've done 13 cases, and our average time outside of the NICU, so that's leaving the door of the NICU and coming back in, is 2 hours and 8 minutes. Time out of the isolette is about an hour and a half. Our procedural total is actually only 40 minutes, and access, that's including access, and access itself takes about 7 minutes. So you can see here in both of these, time outside the NICU or time outside the incubator, over half the time is really spent doing other stuff. It's not the procedure itself or access that's taking a long time. It's not even necessarily the transfer or the transport from the NICU to the cath lab. It's all the stuff around anesthesia, getting the patient on the table, getting them prepped, all those other things that need to happen. And so that's where we're really trying to focus on to decrease the time of the overall procedure. And one of the things we're working towards is actually doing it at the bedside. And that's using this device. And it's a portable C-arm that really actually fits beautifully over the isolettes. And it would enable us to do this at the bedside and then eliminate the transport of the babies and a lot of the time out of the isolette, where those patients are at risk of getting cold. We continue to learn. We continue to find small things to improve. A recent case, the nurses didn't have OR scrubs, so we had to wait to get the right gowns on them. That's after they showed up to the cath lab. A shuttle got disconnected too early, so we recognized that it needed, at what point it needs to be disconnected. And we just improved the way that the lines were oriented. Joe and I went up and did a little simulation and improved how the lines were oriented before the kid ever gets to the cath lab to try and improve the process of patient transfer. So what we really learned is that it really does take a team. It takes repetition. You have to do the same thing every single time, and you need to pay attention to details and be consistent every single time. Do it the same way. We are being transparent about everything we do in order to try and learn from our mistakes, and we're continuously critically reviewing ourselves in order to try and improve and do the best that we can for these patients. This is a little bit of the literature I referenced, and I would be happy to answer any questions as well. Here's my email, and then our the shared email is neocards@vcuhealth.org, which would get you in contact with me or Dr. Khoury. So thanks for your time. Happy to answer questions.
Thank you, Dr. Khoury and Dr. Casella. Does anyone have any questions? I don't see any Q&A right now, but feel free to come off mute if you prefer, or you can place it in the chat or the Q&A.
So great afternoon. I don't have a question, but have a comment. This is Kelly Evans with the Institute for Public Health Innovation. I value both your forward thinking around the processes. My grandson was born in Florence, South Carolina, but he didn't have heart concerns, but was born 24 weeks and 2 days. But I value the forward thinking around the life of the baby and the inclusion of the parents as well. So thank you both, Dr. Casella and Dr. Khoury, and the work that you do in taking into consideration, even doing simulations of what could happen and what could not happen. Thank you both for the work that you are doing for our babies and their families.
Thank you for that. We
Thank
really
you.
appreciate it.
Any other questions at this time? Got a little bit of kudos in the chat. Someone said great presentation and the work you're doing is showcasing outcomes. If there aren't any other questions at this time, I'll remind everyone that this is a recorded webinar and you can find it on VNPC's YouTube channel. If you just go to YouTube and look for @GoVNPC. And if no one else has any other questions, we can end for today. Look out for our next monthly webinar and our special webinar series that you can also find on govnpc.org. Thank you, everyone.
Thank you. Bye-bye.